All right. Who wants to start? Ahmed, you want to start, Ahmed?
Yes, please. Assalamu
Right.
alaikum.
Salami, hello.
I'm 66-year-old man, an ex-smoker with hypertension, hypercholesterolemia, and undergone diaphragm bifurcated aortic graft and bilateral ureteric stents for inflammatory aortic aneurysm with ureteric obstruction at another hospital 4 years previously. The left limb of the graft has been anastomosed to the common femoral artery and the right limb to the common iliac bifurcation. Postoperatively, he had suffered mild groin wound infection, which had healed with antibiotics. At follow-up, he complained of left calf and thigh claudication. On exam, he appeared generally well with midline abdominal scar and left vertical groin scar. He had good right femoral pulse, but an absent left femoral pulse.
Okay. So just had patient has an inflammatory aortic aneurysm. And how many years? They said how many years? 4 years ago. Okay.
4 years, yeah.
Now he came with a left leg claudication and the left limb, no left groin femoral pulse. Before we go to that, let's talk about inflammatory aortic aneurysm. What do you think is the best treatment for inflammatory aortic aneurysm these days? Open or endovascular?
Open repair. Endovascular, you introduce another foreign body.
Not, have you seen inflammatory aortic aneurysm repair? No, I'm sure.
No.
It is very, very tough because everything is inflamed. You go there and you see like the Murasabbat baton, everything is stuck together. So, you know, even the ureter is stuck, the ball is stuck. So it is really very risky. You can get to the ball very easy. So inflammatory aortic aneurysm open is very, very difficult because all the inflammation around it, you know. So open repair is always a risky, but before this is the only options we have. But these days, because of an EVAR, no, I think EVAR is the best option for endovascular. Unless, of course, he doesn't have a neck, whatever. But if you have a choice for inflammatory aortic aneurysm, I think EVAR is the best choice. If you decide to do an open, what the best approach in midline or retroperitoneal?
I would think a new virgin area retroperitoneal.
Correct. Yeah, because again, everything's stuck in the midline. So this is an area where retroperitoneal approach is better than midline. So you don't have to go through the bowel and everything. So I think inflammatory aortic aneurysms, it's nightmare. I see Ali here. He signed with us. Ali, how's your experience of aortic aneurysm as an open? Is it a nightmare or what do you think?
Inflammatory, first of all, good evening. Inflammatory aneurysms, you mean?
Yeah,
because
aneurysm as an open.
It is very difficult for a surgeon to approach these aneurysms. I think endovascular is the best option if you can do it. I think it is, or you have to prep. If it is not urgent, you have to prepare with cortisons like this, and then you can try.
Right. But I'm trying to tell the fellows who doesn't have much experience, it's not a fun to go through this one. So if you can't avoid to go through an open during the vascular, I think it'd be much better because open is really tough. All right. So this patient came with from this was a question. Let's go first question.
What should be the first investigation?
So go ahead. Yeah.
DSA and geography.
DSA and geography, angiogram. Do you think that will help?
That can be diagnostic and therapeutic, but would be the first?
No.
Not really.
Yeah. Okay. So it's wrong.
Duplex ultrasound scan of the aortic graft. It tells information. Yeah, it can be. Yeah.
I think it's what you do usually. If you get first, you do ultrasound just to confirm the occlusions. Even though diagnostic, clinical is diagnostic, but also ultrasound tell you if any fluid around the graft, any inflammation, you know. But this is all usually start with some symbol, which is duplex ultrasound. Okay. What about?
Third choice, technetium labeled leukocyte scan. This is to know the extent of the infection of the graft.
Yeah, but at this
later investigation.
Yeah, we don't know yet. And I just told you the infection, but until now, we don't know it's an infection. So until now, we don't need to do it because no sign of infection. It just came with a thrombosed limb, you know. So we don't need to do it. Okay, next.
CT angiography of the graft should be for the planning of further surgery, if
Yeah.
indicated.
Yeah, so we'll do it. Yeah, I mean, like this patient when he comes, you do an ultrasound and then you do a CT angiogram to confirm the thrombosis, what the reason for thrombosis, any kink in the graft, you know, any infection. So you order CT angiogram because you're not going to do any intervention ultrasound because you don't know what's going on. So I think CT angiogram is important. Yeah. What
And
else?
finally, ESR, it's a lab investigation, yes, to provide an idea about the inflammation.
Yeah, but we don't have a sign inflammation, Ahmed. You see, we don't have a sign inflammation. I mean, from the story, he has no sign of inflammation. He just had
Only
thrombosis.
occlusion.
We don't need to do it. Yeah, so we don't need to do it. So now, this is a routine. Patient come to you, you just do an ultrasound or CT angiogram. You know, most of it I'll jump to CT angiogram because ultrasound doesn't give you some information, but not as good as CT angiogram. I need to do CT angiogram anyway. You know, so unless you do, but you can get all from CT angiogram. Yeah. All right. So let's go next. Hamad, want to take one? Hamad Dahman, is he there?
Yes, doctor. So a duplex.
Before you start, I see Hussein here. Hi, Hussein, how are you?
يسعد مساك ابو بلال.
Hello, Hussein.
حياك.
What are your experience with inflammatory aortic aneurysm?
I just went in يطول لي عمرك.
Sorry?
I just went in.
Yeah, I just nothing. We're just talking about, this is a case, let's go through it. So, you know, this is a patient who has inflammatory aortic aneurysm 4 years ago, and he came with left leg claudication and showed that has no pulse in the left groin, that's all. So occlude his left limb. But I'm just talking to the fellow about inflammatory aortic aneurysm. Just tell them that open repair is not the best option because it's very difficult. So because fellows, they don't know that. They never see inflammatory aortic aneurysm. So I just want to, if you can tell them your experience. Is it a nightmare? It's easy to do it, you know? Do you prefer endovascular or open for inflammatory aortic aneurysm?
Definitely open is a nightmare.
Yeah.
I wouldn't do it at all, and definitely I will try as much as I can to do it in endovascular.
Yeah, I agree. Yeah. You see, people, they don't see, they don't know it. I told them when you go there, it's just like stuck. Everything's stuck. The ball is stuck, the ureter is stuck, the duodenum is stuck. Even if you try to dissect the duodenum, you get through the duodenum, you get bowel perforation. So it's
In fact, you will harm the patient more than you will benefit him.
Yes. So endovascular really, it's a blessing in this situation. All right. So we go back to Mohammed Dahman. Continue.
Yes, doctor.
Go ahead.
I have a problem with.
You can see it.
Now. Yeah, a duplex scan showed occluded left limb of the aortic graft with patent common femoral artery. There was no evidence of any stenosis of the left common femoral artery, but perigraft fluid collection was noted around the intra-abdominal portion of the graft. This patient, I think he started with ultrasound actually.
Yes, he saw ultrasound and he saw a fluid. You know?
Yeah. So he saw fluid and he saw occluded limb.
Okay. So he has an infection.
Yeah.
This is the reason why. Yeah. You see, this is the right limb. He did that. This is the left limb, which went to the common femoral. The right limb was a common iliac, and this is the reason why nowadays we prefer to do bi-iliac than bi-femoral. The old teaching, when I was in my residency, we always, taught that to do aorto bi-femoral, never do aorto bi-iliac. And the reason why, if you get any stenosis at the distal anastomosis, you can fix it through the groin incision. You know, you don't have to open the belly. You see, this was the idea behind it. But nowadays, because it's endovascular, and you can fix everything endovascular, you can go through the femoral, go through the anastomosis, put a cover stent or a stent. You can fix endovascular. Now things really is better to do aorto bi-iliac because there's chance of infection because we don't go through the groin. See how things change now, you know, from old teaching now because of that. So that's what happened if you go to the groin. Sometimes you get an infection like this one. Like, okay. So what do you do now? What do you order? You did ultrasound. Then what next test we'll do now?
CT scan.
Yeah, of course. That was they did here. And you can see What do you see here?
Air bubble.
Air bubbles.
And
Okay.
like, yeah, there is fluid around it.
Okay.
Yeah.
Let me ask you, if you do an open AAA and sometimes patient eyes, next day he has abdominal pain, drop hemoglobin, you know, or a couple of days after procedure, do a CAT scan, and you see a lot of air bubble around the graft. This is normal?
Post-operative, yes, it's normal.
Or
But
how
if it's exceeding more than 6 weeks to 2 months, it's abnormal, I think.
Yes, usually most of the time in 2 weeks should be disappear.
Yeah.
You know, but if it go for more than like month or two, I think it is abnormal. You know, the same for fluid. It's normal to see a lot of fluid around the graft after surgery.
Yeah.
All this normal up to a couple of months, but after that is not normal. But after surgery, because what happens, the CT scan, he doesn't know in the surgery, also report a gas around the graft. So don't get scared, you know. It's a
Yes.
graft around the graft after surgery. But usually 2, 3 weeks, 4 weeks maximum, they should disappear, you know.
Mhm.
All right, so let's see what they said. Here was a question.
What further investigation should be performed? He put CT scan again of the graft. I don't know why.
I give you the answer already. So you do a
Yeah,
CAT scan. What else?
For me, I'll start with CT scan.
Correct.
If still I'm in doubt, I will order WBC scan or PET scan.
Okay,
If
but
I'm
now
not sure if
you
it's
did a CAT
infected.
scan, Ahmad. You did a CAT scan. This is what showed. You did a CAT scan. This is what showed.
And this is confirmation. This is confirmation that I have a infection. I don't need anything more after this.
What about thallium scan? You don't need it?
Thallium scan, like you mean, yeah, PET scan. I don't think I need it.
What about angiogram? Do you think that will help?
No help. No, it will not help. Yani because it's thrombosed and infected. If it's only thrombosed, I might use angio to try to recanalize and clean or thrombectomy.
Yes,
But
I'm so confused. We talk about this
okay.
case. Okay, so it's
This case I don't need. I don't need anything after the CT scan.
you don't understand.
Mm.
So digital angiogram, you don't need it. PET scan, you said you don't need it.
Yeah.
Okay, what about ES resource cementation rate, resource height?
ESR for the
Yeah.
infection. Yeah, this is with the basic labs.
Okay, what about aspiration of the collection? You aspirated?
No, it's very dangerous to aspirate.
All right, let's start one by one. CT scan, I agree with that. Angiogram is useless. Thallium scan, I mean, this case you don't need because it's a gas. But let's say it's no gas. What are we going to do? I see fluid. You
Yeah,
see?
if I'm in doubt, I will use PET scan or WBC scan.
All right, so if you need that, but like this one has a gas,
Yeah.
I want to see an extension, but I think this is more than enough. So I don't think you need it, you know. ESR, I mean, it helps. It's not very important. It helps. Especially if it's a collection. Some people, they do that. You know why? It's not dangerous. No, it's not dangerous because you can go CT guided. It's not dangerous because you don't have an endo leak, nothing. You're just getting the flu. But why you need it? Why people do that? Why do aspiration?
To confirm the presence of bacteria, I think.
No, you know the bacteria there, but you want to know what the type of bacteria. So you can
What
give
is the type? Yeah.
So this
Cultural
is
sensitivity.
correct. So what the most common bacteria you see in graft infection?
Staph aureus and Staph epidermis.
What's the difference?
Late infection or early infection?
Which one for the infection?
For early infection, Staph aureus. For late, Staph epidermis.
Correct. So yeah, but you can find else. What if you find gram negative?
That means I might have aortoenteric fistula.
Correct. So if you can see, or you can find what else you can find?
Salmonella, syphilis,
Brucella,
Brucella, TB.
Right. Can you do like irrigation of the sac with antibiotic as treatment?
As a definitive treatment, I don't think it will be beneficial, but some very difficult case, I think, yeah, but not like a definitive management.
Yeah, some people have high risk for operation. Some people
Yes.
they do irrigation. They put like 2 drain, and they
Yeah.
get continuous irrigation antibiotic. I think this for patient high risk for surgery. You cannot go through a surgery. I think this is something some people do that. So it's a straightforward. I don't know if anybody want to add anything before we continue. All right, let's continue. Who's next? Let's take who's there here. We have Zahra. You want to take Zahra?
Yes, doctor.
Okay, let's continue. CAT scan.
Okay. Having confirmed the presence of infection, what is the best option for management?
No.
Prolonged
Here, CAT scan confirm. Let's go. Yeah.
sorry. A CT scan confirmed the presence of fluid and gas around the intra-abdominal portion of the graft and the occlusion of the left limb, indicating graft infection. DSA confirmed the occluded left limb of the aortic graft and showed a stenosis at the origin of the right graft limb. Presumably as a result of external compression, aspiration of the perigraft collection would have allowed preoperative bacterial culture, but was considered to be too difficult to perform safely.
Okay. So that's what we said before, that you can do it, but you have enough fluid, but some people they do it just to get some culture so they can start specific antibiotic. Otherwise you have to give a broad spectrum antibiotics. All right, so let's go to question number 3.
Okay. Having confirmed the presence of infection, what is the best option for management?
Okay.
A, prolonged antibiotics therapy. B, drainage.
Let's start one by one and let's see which one is correct or wrong, because it could be all of them correct. Prolonged antibiotic therapy could be an option.
Yeah, we should start antibiotics, and he will need a full course of antibiotics.
But it's not the best option for this patient, right?
Yeah.
It is, unless the patient cannot operate on him, then you just put him on lifelong antibiotics, like patient high risk for surgery. This is the only thing you can do, right? All right. What next one?
Drainage of perigraft pus under anesthesia, no.
It's not the best option, but again, some people they do that sometimes to buy time because the patient is very sick, so you can do like a drain the fluid, give antibiotic, and buy sometimes until you get like better. So because these patients are sick patients, it's not easy to take them to surgery. You don't die on table. And again, patients high risk for surgery. Some people they do it as definite, but again, this is just a bridge, or this is just only in time patient cannot have a surgery, but it's not the best option for sure. Okay.
Insertion of gentamicin. It's also not
definite. Okay.
Option. Excision of the graft, yes, but we need to do another graft.
Can you do only excision without any bypass?
No, because
yeah, go ahead.
Because he already has symptomatic lower limb.
Okay, but I see some people get away with just excision without any bypass, but it's not the best thing to do.
He came with occlusion. He came to the hospital with the symptoms of lower limb.
Right. Right, but the whole idea is that sometimes you don't want to graft longer surgery. Patient is too sick, just get him off the table. So if you come with a chronic occlusion, it's better because it has good collaterals, when they come. So if the graft is occluded, it's better. Then you can, if patient comes with occluded infected graft, I mean, maybe it's the best way, just take the graft out and do nothing now, because that's the best time to do any bypass or reconstruction, you see. So, but if patient, the graft is functioning, it's a problem. And he depends on this graft, then if you excite the graft alone without any reconstruction, you may end with a lower extremity ischemia or amputation it depends how much his collaterals, But it's not the best treatment, but sometimes you can get away with just excision, the graft. Yeah. Okay, next.
Next, excision of the graft with in situ replacements with an antibiotics bounded graft.
Okay. Do you think it's a good option?
No, better to do extra anatomical or vein graft.
I mean, it's controversial. We don't know what's the best. Everyone has, issues, what they think. Before external anatomical, now really these days, because I have strong antibiotic, most people like to do in situ. The problem with external anatomical bypass is stump blow up and ruptures the stump, and they can die, which usually happen about 25% of the patients, or aneurysma dilatations. So really external anatomical is not the best. Now, if you can really put in situ, something in situ would be better if you can, Some people advocate to use antibiotic bonded, as mentioned here, or you can use a lot of things you can use really. Or you can use a silver graft, or you can use, what else? Tell me what else you can use. In situ, you can use a vein, right?
Vein.
Or you can use, they mentioned here, or allograft, right? Or the allograft.
Yes.
And now recently they start using, I didn't use it yet, but people using that is Dacron graft. They get the Dacron graft, make it like a tube, and they put it in place. So this is all options available. So really all those options you can do them. Each one has a plus and minus. We're going to talk about it now in details. So silver antibiotic graft is good. It's quick. You don't have to harvest the vein. You don't need external anatomical in a place. And some people showed a good result, but the problem is reinfection still. It's about, I think, 13%, 15 to 13% get reinfection, Using in some people, they said, why use it prophylactic instead of when you do like a normal aorta biofilm, why you just use silver or antibiotic bonded graft? Nobody showed that using it as prophylactic would decrease chance of infection. So, but a lot of people, they use it now these days. If you don't have much infection, like, you see mild infection, but you have like a pus range and everything, I don't think a good idea to put a graft. So you have to make a decision during the surgery. External anatomical bypass, of course, this is a standard old fashions, nobody argue about it. But again, I think less people do it, but yes, this is maybe one of the best option. Autologous vein. They use a vein. You know which vein they use? What the most common vein we use? Because aorta is big, so you have to go to the superficial femoral vein. You have to go deep vein. So usually you harvest both deep vein, and you put them as aorta biofilm. It's a lengthy procedure, but it helps. And last thing is allograft from cadaver. The problem with the allograft is that I see a lot of thrombosis you can get from that. You can get aneurysma dilatations, anastomosis problems. So it's not the best option, really. I'm going to leave the other consultant give us their input because a lot of things to talk about. And this is the main idea of our meeting today, talk about surgery and what the best option. Ali, what do you think, Ali? What's your best option?
My options are or silver graft, Dacron graft, or bilateral axillobiofem, femoral.
Okay.
From any side, one side and one side, left and right.
You separate, you mean both axillofem separate or one axillobiofem?
Axillofem.
Axillofem. Okay.
Yeah.
Why not axillobiofem? Just curious.
I think that the area will be infected, so it's not better it's not good to pass the one limb from one side to the other. So you have to remain only every side alone, I think.
Okay. What about antibiotic bonded, like rifampicin? You ever use it?
I have no experience.
No experience, yeah. The people who use it really, they show the good results, with the rifampicin, but you have to read it for 20, 30 minutes, people show the good result. But yes, what about vein? You ever use a vein?
No experience also there, or allografts.
Really, it's the best option, but it's a long surgery.
I think it's a long surgery, and I don't know.
And I imagine patient's already sick, and in fact, less patient stable. But yes.
Yeah.
Hussein, what do you think, Hussein? What your best option you choose, Hussein?
أول شيء يسعد مساك دكتور علي. Happy to hear your voice again.
يسعد مساك.
Now, Samer, let me ask you, you were talking about Dacron graft. that they're using, or what type of dacron graft that they're using now? Is it the different dacron that what we use usually?
No, the same dacron, but they just bring it and put it in the rifampicin.
Okay, okay.
It's a special concentration, I think 1 or 2 grams, but you have to soak it for 20 to 30 minutes. And then you put it, the same one, you just put in the antibiotic. And most people just good results, really. But these days, really, I think most people, I see what they do now. It's very simple and very quick. The bovine patch, you use bovine patch, right? The bovine patch is a big one.
Yes, yes.
Yeah, the same one. They make like a tube. They turn it, put like a tube, they cut with tube and they suture, become like a tube. And you can do bifurcated. They use it and they have very good result. And I think it's very good because they're thick, graft, and we use it all the time as an infection. So people now, they use it for aortic graft now, and they show good result, really. Yeah.
Okay. One other point which you mentioned, I think it's very valid. Depending on would you go any bypass for this patient at this stage, or you would wait? And this is, as Dr. Zahra mentioned, depending on the patient's condition. Does he need it at this stage, or no, we can postpone it until later? Especially that this patient is a chronic and he already developed a lot of collaterals. So urgency of doing a bypass depending on the patient's condition. I would go for eggs bifim rather than eggs fem. Maybe Dr. Ali has more experience that he thinks that it's more infection if he does the eggs bifim. I never thought of this, but I think I would go for eggs bifim. I never used the vein and never used this bonded antibiotic grafts. But silver, I think it's a very excellent choice. And I think it's not very common grafts. I think only McKay has this, the silver type. In fact, we try to use it if we have any suspicious of a patient. We use it from first surgery rather than for later. I mean, we have it, so we just use it just to avoid any infection further. This is my experience. But again, the point of, I have a patient which I've been following for the last 10 years. He's a young guy. After 3 years, he developed aortoenteric fistula. I had to go and do for him X bifim and just excise the graft. After like 3 years, it got occluded the X bifim. Now it's like 6 years or 5 years I've been following him, no bypass, nothing, and he's just having normal life. He's walking and he's happy. So I'm just wondering, did I have to do for him the first surgery or not?
No.
If he's still able.
No, not really. If he's asymptomatic, I'll leave him alone. I mean, a lot of people, I see them come with a complete aortic occlusion and they're living normal life with a good collateral.
Exactly.
But again, now these days, the most common already used is rifampicin pounded silver graft and the dacron, tube graft, bovine tube graft. And exonomical, of course, still there. It's an old fashion, but it's still there. People do it, Autogenous vein, I think, is very good. I think it's the best option from all this one. It just takes long time, Allografts, we use it. I use it one time. You have to replace the whole thoracic and abdominal aorta. I mean, patient is fine. But another partner, he has one, but he got anything infection or occluded or something like that. So you have to take it back again. So I don't think it's the best option. And it's not always available. So I think most of the time we'll stick with exodomical bypass, or if you do something, then you have to be either silver or antibiotic bounded graft. But again, I mean, try to use the dacron, something new. And I think this is something really, hopefully will work fine. For the fellow, if you use a vein, we use a femoral vein, as we mentioned. But two things you have to decide to do. First, you have to leave the profunda open. So you have to cut it after the profunda. So you take the superficial femoral vein, not the common. Otherwise, you cut the flow to the legs. And you go down all the way down to the knee. You don't go below the knee because you need to keep the flow to the legs. So the most important to be sure the profunda is open from the vein and to keep it open. So you resect after the profunda all the way to the knee. This is what piece you take it. And most patients, they do well. They get some swelling, but this usually go away with the time. Yeah. All right. I think we talked about everything here. For anatomical bypass, what you do first, aortobiofem, or you do the aneurysm first? Azara?
Aortobiofem first.
You resected first the graft, and then you do axillobiofem, or you do axillofem first, and you do the resect the graft?
Yeah, then we will remove them.
So I didn't get it. So which one's first, the axillobiofem or the graft? Remove the graft. Or both at the same time, or you do them both at the same time?
No, we will start with the clean surgery. Then we will start after closing the wounds. We will start with the infected area.
Okay, but people, they don't like to do same days, So most people do axillobiofem first, and then next day or day after, they do the aortobiofem. Unless patient's too sick, you cannot go for 2 surgeries, then you do them same day. But always start with axillobiofem first, But remember, if you're dealing with the aortobiofem and the fem is infected, you don't want to put your graft to the femoral arm. Then you have to go to the profunda, or you have to go to the SMA, or you have to go more distant. But don't take the graft from the groin, which is infected, and put it axillobiofem on the groin. You have to go away from this infection. You don't want any chance of infection because you're putting a graft again. See? You just have to be careful.
And for this reason, I said that I make axillofem, bilateral axillofem, not axillobiofem, for this reason.
Yeah, so you can go distant.
So you can, and you don't pass in the infected area. I think it is more important not to pass in disinfected areas.
Axillobiofem.
What?
I think we have that for noise. Yeah, I'm saying an axillobiofem, and the axillary, the graft got clotted, then both femoral graft clotted. But if doing it separately, then if one clotted, that's working, different, but it's something you can think about it. All right. Dr. Hazim, you're here, Hazim. How are you, Hazim?
Fine, thank you. Sorry, I was been late. Sorry, I was in operation room. I don't know if you can see me because I am via my mobile.
We don't have to see you. It's enough to hear your voice. Thank you, Hazim.
Thank you, sir. Thank you, sir.
How is your experience with the infected graft? What's your best option? What do you do? You have infected aortobiofem graft. Do you do in situ, it's anatomical? And if you do it, what's best graft you use?
So, actually, over the years, our strategy here in Mainz University Hospital have been a lot changed. So we used to implanted the umbilical vein till 2009. But after that, and till this moment, we used actually depends, first of all, depends on the patient's strategy and the patient's status. So if the patient is able to survive, or it will be not a big problem for him to get a long surgery time, we take always and we prefer always as a first as a first choice the deep femoral vein, the femoral vein. So it's our first of choice. If there is some issues which contraindicate to take the femoral vein, so we go to pericardial patch, or we use a new technique or a new described method. It's the bovine biosynthetic graft. This is the OmniFlow graft. I don't know if you are familiar with, sir, or everyone is familiar with this graft or with this material, the OmniFlow material.
Is different from the bovine patch. The bovine, talk about the bovine itself. The bovine patch makes like a tube there.
Yes, yes. The bovine, as you know, we got it as 25 centimeter per 25 centimeter, and we make a lot of combination. We can also make something like also like Y graft. We make also something like jumping graft to the renal. We are able to make all kinds of reconstruction, aorto-iliac or aorto renal reconstruction with the bovine. But this should be have usually two teams. Two professional team, one team from for the graft preparation and one team for the whole operation. Or if you are gonna to work solo, it will be take a long time, and before cut down you should prepare your grafts, but it takes a long of time because you need to sew double time to secure your reconstruction.
Hazem, do you have any good data about this graft, the patency? Do you have any data, or is it just experience?
No, till now there is no public. We didn't publish our data till now, but it's a very important point, and actually we are talking now about a new paper. We are planning a new paper. All sorts, all kinds of surgery. We are gonna to compare or our strategy in as a monocentrum paper, and we are gonna to put our umbilical vein, our femoral vein, our omnigraft, and our also pericardial patch or pericardial bovine reconstruction.
Okay, let me ask you, what is pericardial vein? I don't understand. This is very small. What is pericardial vein?
So, pericardial vein, I mean, about pericardial vein, I mean a pericardial graft. So we are able, can you see me? Or it's not able here, because I can show you a couple of pictures of our reconstruction, how we can, how far can we go with the pericardial patch also. So I am talking about combination with pericardial patch and vein material.
Okay, okay. Can you share with us?
So as you know, sir, it's very difficult. We have some issue of the lung of femoral vein. We are not able to make aorto be femoral with only vein material. So we go to a combination from pericardial tube and like a legs from the vein material.
Okay, okay, I got your point. Can you share this one in the group? Some picture, some technique, how you do it, guys, because it's an important, especially with the bovine, because bovine patch is very available here in Saudi. It's available every place, so it's easy to do it. So if any tip,
I can tell you there is a case where and EVAs were explanted by me 1.5 years ago, and I implanted a silver graft by infection also. So the patients come again with a sepsis. So for this reconstruction, we made aorto B iliac with reimplantation of the both renal artery. All grafts were made from pericardial patch.
This is good. Yeah, I see that many times. It's very interesting, you know. to do that. So it is nice to show us some picture or a special technique if you have, you know.
It's somehow confidential, but I will try to make it and to put some pictures.
Okay, that will help really.
Okay.
What about antibiotic bounded rifampicin bounded graft? Did you ever use it?
Actually, by every aortic replacement, I try to soak my graft with rifampicin. It's never, I don't care if there is infection or no infection. I use always, I take my safe side, and I use always to soak my graft in rifampicin.
Yeah, but hasn't no data showed that will decrease your chance of infection, but maybe make you feel better. I don't
Yes, yes, but I got this strategy from my ex-mentor, Professor Dorweiler, and you have right. There is no data, but it's. I am talking about.
Yeah, yes, yeah, experience. You know how you do it. Hello. I think we lost Hazem. Guys who doesn't know Hazem Beiruti, he's a consultant in Germany. He has a good experience with aortic, you know, surgery. He's a very nice person also. All right, let's keep going.
But he's from Trablus.
I'm back, huh? All right, Bassam, I didn't hear your voice. Bassam, you want to go?
Yes, thank you.
So sorry, I am sorry. I am back. I want to apologize from all members. Sorry for all colleagues.
Okay,
So,
Hazem, continue what he's saying. So,
Yeah.
so now routinely for all you put your graph in rifampicin.
yes.
Okay, do you suck it for 20 minutes, 30 minutes, or just put like for 5 minutes?
Sometimes less than 5 minutes.
Okay, because they said you have to do it for 20 minutes. Anyway, what about axillobifem? Do you still do it or rarely you do it? Axillobifem and suture the stump.
Yeah, but last time I did it at night as emergency case, and was about 7 years ago.
Yeah, so now always we try to put something there.
Yes. So I can tell you, sir, this month we got about 7 infections, and 3 of them, we operate here not only as a university hospital in Rheinland-Pfalz. We are obligated to accept all patients from other peripheral hospitals as a university hospital here. So we got a lot of complication. So in this I am talking about December, sorry, not January. So and in this 7 cases, we did 4 with a vein and the 3 with a pericardial patch.
Okay, that's very nice.
So, but there is a really very nice trick, or very nice also variant, or another acceptable choice is the OmniFlow graft.
Yeah, which you're going to put it in the group so to explain to the people how this works. Okay.
I will pay. I published. I published a couple of months ago. So and is now on PubMed, and I will put it on the group. Okay, sir.
Let me ask the last question, because you mentioned the vein graft. I gave 2 tricks, but you can give 2 more tricks. First, you have to leave the profunda open for sure. You have to harvest the superficial vein, not the deep femoral vein.
Yes, of course.
The knee. This is
Yes.
enough. More tricks.
Yes, it's very important not to leave any kinds of stuck or any millimeter from the femoral vein, because if you leave any couple of centimeter, of couple of millimeter of this vein, there will be a big or a lot of
DVT.
DVT, yeah, a lot of risk for DVT. You should first of all, we need every centimeter, and please try to harvest all the vein grafts, all the femoral vein. Don't leave any centimeter, any millimeter.
But this is after the profunda, right? Superficial femoral vein, correct?
Yes, of course. You should have to leave one blood supply.
Correct. Okay, that's good. Excellent.
And what I use now, what we use now, not only, I use something like lymph drainage after the operation. It's give like C wave motions on the both legs, and this help a lot to prevent deep femoral thrombosis, vein thrombosis. There is a system you can put on the leg, and it will give you like a pressure, C wave pressure, and it will prevent you to get a deep vein thrombosis.
Like you call them sequential compression devices.
Yes.
Intermittent pressure, no?
Intermittent pressure, yeah, this is the one, the SCD, yeah. All right, let's keep going. So number 4, Bassam.
Yes, sir.
So in situ replacement.
Yeah, in situ replacement with the autologous vein was chosen because of the reduced risk of persistent infection, which autologous vein may be used for aortoiliac or aortofemoral graft replacement, as we mentioned. Yeah, long saphenous vein is not an option because it's small. Cephalic vein is not an option. Femoral popliteal vein is the one. Yes, iliac vein. No, it's probably it's a little bit thin. Femoral popliteal vein.
The length from the iliac vein is short.
And the length, yes, it's short. Yes.
I need a long. It's aortobiofemoral, aortobiiliac. So iliac vein is usually short, so it's not a good option. Okay, let's continue.
Yeah, femoral popliteal vein was used as it is ideally suited to suprainguinal graft replacement, as it is relatively thick-walled, is of adequate diameter, and has sufficient length. Yes.
Okay.
Number 5, what further preoperative investigations should be performed? Plain abdominal X-ray.
For the legs to see the vein is good or not, what do you do? Because if you want to harvest the vein.
Plain abdominal X-ray is not useful. Bone scan also is not useful. MRI scan of the abdomen, no need for it. Duplex scan of the femoral vein, yes. We have to assess the femoral vein to rule out DVT and to measure the diameter of the vein. So duplex ultrasound is the best option. Repeat abdominal ultrasound scan.
You don't need that.
No need. No, we don't need it.
You just need to ultrasound to be sure the vein is open, good size. Should be at least 1 centimeters,
Diameter.
The profunda is open, because the profunda is occluded, I think could be contraindication, because then you have no outflow for the legs,
Yeah.
So if you have no outflow, you end with what? With compartment syndrome,
Yeah. Venous gangrene. Okay. Venous ischemia.
Yeah. All right, let's go back to Ahmed. Go Ahmed.
Yes, please. What other preoperative preparation should be undertaken? Routine full blood count. I think yes, to know the hemoglobin status of the patient.
Okay.
At least. Urea and electrolyte estimation.
Okay.
To check for renal function. I would say yes. Chest X-ray and electrocardiogram is not routine for any patient.
No, Keith, how is that? We do chest X-ray EKG. They will not put patient to sleep before chest X-ray. So it's normal.
Yeah.
Right?
Yeah.
Yes, so no, you need to do it. It's like routine. I mean, this is not a question really, because this is something we do all the time. Nothing about it,
Yeah,
So-
but because of our last discussion and patients who are young, I don't know if they have to have all of these together. Anyway,
No, this is any surgery you need to do already. CBC, renal profile, chest X-ray, and electrolyte. This is routine for any
and
surgery.
ECG.
And EKG. Yeah,
Mm.
EKG, because arrhythmias, block. So this is the minimum that anesthesia requested.
Yeah.
Let's go next. Compression stocking.
Preoperatively, compression.
We don't need that. Usually
No.
after surgery, right? To
Yeah.
prevent, but we don't give it before surgery unless the patient's bedridden. It's a different story. But this is a young patient. Okay, what about sub-Q heparin? The same things. If patient is bedridden, you give him. If it's not, you don't need it. You give it after surgery.
And finally, combination antibiotic therapy.
Yes.
In a bridge before starting the would give him.
Right?
Yeah.
Patient has infection, so you have to start antibiotics.
Yes.
Yeah, and you have to give a wide antibiotic unless you do a CT guided drainage. You know what bacteria you're dealing with. If you don't know, just give a
Broad
wide
spectrum.
antibiotics. Yeah. Okay. So nothing really is not good question. Let's continue here. They did everything. Let's go to question 7.
How should the operation be performed? A laparotomy, excision of the aortic graft, harvesting the femoral veins, and the graft replacement.
Okay.
That sounds sense.
Okay, let's go next one. They try to see which one you do first. This is the whole question.
I see.
First, or you do excision first. This is, I think, the main question.
Okay.
What do you do first?
Harvesting the femoral vein, then laparotomy, excision of the infected graft, and replacement with femoral vein.
Okay. Why you harvest the vein first?
To make sure that you have enough length graft.
Okay, it's one other reason.
Plus, you're gonna start your bypass.
Go ahead.
You start your bypass before explanting. I don't think.
What about C? You do laparotomy, expose the graft, then stop, get the vein, then replace the graft. What do you think? It's a good option?
You will expose whole areas for the infection.
I don't think it's the main reason, because you're going to get everything infected, because when you take the vein, out, I mean, you always can get an infection there, but yes. But the main reason always, you never open the abdomen. You don't want the bowel to be exposed outside and lose the fluid and everything. The abdomen should be open the last, This is the whole idea. You don't want a bowel open to the air like for hours, while harvesting the vein, because you lose a lot of fluid, and get edema and swelling in the bowel, get an ileus, all those issues. So always, like when you do aorto bifem, I always open the groin first, expose the femoral before you open the belly, So always try to leave the belly to the end. You don't want to keep the abdomen open for a long time. So always harvest the femoral vein, then open and do surgery. All right, nothing really important here. Let's continue. Who's there? Mohammed Ahman, you want to take over?
Yes, doctor.
Just describe what they did, which is nice. Let's
Okay.
see.
They anesthetized the patient, was catheterized, prepared, and draped so that abdomen and both legs were exposed. First, both superficial femoral vein were simultaneously dissected out by 2 operating team, and the branches divided between the clips and the profunda femoris vein to the knee joint. The femoral vein were left in situ while the abdomen was open, exposing the graft, obtaining control of the proximal infrarenal aorta and right common iliac bifurcation. The graft was encased in.
You see what they say mentioned very important here. They say they left the vein in situ, so you don't vein out, because also you don't want the leg to be, without venous for a long time. So you expose it, but you don't take it out until you're ready. And you take it out. So this is how step here. They mention it. Okay.
Okay.
Okay. Let's continue.
So the graft was encased in fibrous tissue, making dissection difficult and hazardous. The underlying prosthesis showed poor tissue incorporation, and there was a localized abscess between the graft and the jejunum. which was evacuated and cultured. The left groin was exposed, obtaining control of the common femoral artery, its branch, profunda femoris artery. After systemic heparinization, the vessels were clamped and the infected graft were excised and sent for culture. The graft bed was washed out repeatedly with povidone iodine and hydrogen peroxide.
Okay. Wow. Let's continue.
One femoral vein was excised, reversed, and inserted into end from the infrarenal aorta to the right common iliac artery bifurcation using 4O proline. Size discrepancy at the aortic anastomosis was overcome by fish mouthing the end of the vein to prevent the angulation associated with spatulation. So the other femoral vein was reversed and anastomosed into side to the intra-abdominal part of the vein graft and to the left common femoral artery.
Okay.
Both veins were led through a fresh tunnel and surrounded by greater omentum.
This is a fish mouth. You just explain how you do the fish mouth. You see, you open it like this way, like a fish. So if you have a vein and big, artery, like called a fish mouth, you cut it like that and you suture it. Yes. And this is just to show us a bypass here. This is iliac and the aortofemoral. Okay, this is a graph. See the vein here and the vein here.
Nice.
Wow. So there's still but omentum.
To avoid contact with the bed of the infected graft, arterial anastomoses were covered by gentamicin and bergenated collagen foam, and the wound were closed with a suction drainage. Antibiotic prophylaxis and low molecular weight heparin were continued post-operatively. Despite the copious pus around the graft, no organism were grown in the laboratory. Combination antibiotic therapy was stopped after day 7, but augmentin was continued empirically for further 5 weeks.
Well, let me ask you, they said that no organism, so it was a wrong choice, wrong decision to do surgery, no infection?
No, 30% of this patient has no organism growth in the lab.
Well, how get infection, no organism?
So either you get the toxin and you get the pus and it is dead bacteria, but there is bacteria was there, and I don't know what is the other mechanism I heard about too, but
You're right, because patient antibiotic, sometimes you get because patient long antibiotic, you can get a negative cultures, some bacteria is very hard to grow, attached to a graft, unless you're already a good wash of the graft, difficult to get them. Especially what you said, the epidermis, staph epidermis, usually they stuck to the graft, So as you don't see them in the fluid, So it's very hard to isolate them unless you take the graft out and send it to the culture and do a really good wash of the graft, to get them out. So this is the reason. But you have obvious infection. You have an air, you have a fluid, you don't need more of that. So negative cultures doesn't mean you don't have an infection, Then we come to the PET scan. Also, PET scan is not always accurate. It's not always specific and sensitive. Because sometimes you can have a positive PET scan after you put a graft, for a while until become negative. So also it's not very sensitive also. You have to be careful, with interpreting the PET scan also. Before we go there, anything about the technique, guys, the consultant, anything to add about the technique? Was it here?
So they usually use each vein individual, doctor, to the aorta.
Put them together. Yeah, you put one vein and then one bypass, and then you hook the second one from the side to one end to end and one side to end, or side.
Okay. Yeah, I got it now.
Put them together and suture them. No, you don't need that. Yeah. And the vein again, 1 centimeter is still small for the aorta, but still acceptable. And that is the reason why you do a fish mouth. Azim, how you do? You do a lot of vein flux. This is the way you do it, or do it differently?
Sorry, sir.
The size difference. I mean, how you measure the size different. If you have a aorta, 16 is like 16 millimeter, and the vein is usually like 12, 11, 12. I mean, you can get it.
So as I talk, we try always to make proximal anastomosis from the both proximal end of the vein. Then we try to go to aortoiliac. But if there is any art of distalization or femoral, we go with a combination with other component.
Okay. Okay. All right, so let's continue.
But in there is always a mismatch. I have always mismatch when I will in some cases when I will take some omniflow, for example, grafts, and if I have mismatch, I try to make couple of stitch from behind the aorta, couple of stitch to stretch the aorta.
I understand that, Hazim. What do you mean a stitch behind the aorta?
So from behind, I try to minimize the aortic diameter. If there is a mismatch, a big mismatch about, sorry.
Right, you take big bite, you mean?
Yes, with a big bite with some of also pericardial patches.
Okay. Well,
so what he means, he tried to decrease the size of the aorta by putting a couple of stitches from posteriorly, so the opening of the aorta is smaller, so it tried to match the vein size.
Yes.
Yeah, this is dangerous, Hazim, because posterior wall is the worst. Because if you get any tear there, you problems. You know, what I learned in mismatch, we was in Baylor when we do a lot of graft sometimes of mismatch. I always learn you never cheat on the posterior wall, always cheat anterior. What that mean? If you have the graft big and the aorta is small, it's okay. The posterior wall as normal. When you get anterior, you can start cheating
you can manage your complication.
Huh?
You can manage easily your combination.
What do you mean?
If you have some complication or bleeding from posterior, it's not easy to manage this complication. But you have right. Actually, I did it a couple of times, and I did it posteriorly. Unfortunately.
Yeah. Remember, we have a fellow here, Hazim, so we have to be careful. We have to teach him the safe way.
Yes.
The worst part of the aorta is the posterior wall. So I think if you have like the graft larger than the aorta, or which is sometimes you become like 14 or 16, and the aorta for some reason like 12. What happened is that you suture posterior, normal, like you don't cheat. You don't take the distance between the pads, the stitch is the same until you go anterior. Then anterior, you see the graft is much bigger than the aorta. Then you start cheating, taking more graft and less the aorta, but anteriorly. Because if you get after you finish, if you get any bleeding, it's very easy to fix anterior. You just put a pledge or whatever you can do, but don't cheat the posterior wall, because the start bleeding from posterior wall is very hard to control it. So
okay,
posterior half, do it normal. If you want any cheating, cheat anterior, and don't cheat all the way, because then everything will bleed. Like don't from beginning start taking more graft and less aorta, then you put big distance between the stitch, then you bleed from everywhere. So do the posterior wall normal and start whatever you want. Anterior wall is not a big deal. Always you can fix it. Okay, but if bleed from everywhere, then it's a disaster. So just is a small things to put in your mind. Because if I go anterior and I get almost to the end, I see more graft, you can just fold a small piece of graft and put a stitch. It's not a big deal because you're anterior, So the extra piece of the graft, you can fold it and take it with the stitches. But you don't do anything posterior,
Actually, it's a very important point. And it's a very nice trick.
Yeah, we did that all the time, The second thing, like posterior, was we put a tie inside. We don't put it reverse tie. So the tie will be inside the aorta because you don't want to compromise the posterior wall. So we don't care if there's a tie inside the aorta. Aorta is big. So they always put the tie inside the aorta, and then we continue suturing forehand. The most important to do a forehand. So what happened when we finish the posterior wall, we go to anterior, we just reverse our needle and we go forehand. Always you want to go forehand from the graft to the aorta and take as much aorta as you can, like 5-10 millimeter aorta. Don't take small bites, you know. And because you have to get it right from the beginning. You cannot redo aortic anastomosis. You cannot do it. And it's very hard to redo it, especially if you have a fragile aorta.
I have a question. In case of infection, as we are talking about infection, do you secure your suture or your first posterior suture with a Teflon pad?
Because after you finish the posterior graft is still open, you put a pledge. Even I can put it inside. You know, you can put the pledge inside.
You don't have any concern about infection and the pledge?
No, because
Okay.
this is if you have concern about the wall, it's very thin. You're afraid you may bleed from posterior wall. So after I finish the posterior wall, before I do the anterior, so graft is still open. You know, I put a couple of pledge inside. You know, couple of. And I see that they do that in the arch. I saw them do it all the time. They put pledge inside. It's not a big deal. Aorta is big, so putting a pledge inside is not a big deal. You know. So the most important to secure your posterior wall. The more you secure posterior wall, posterior anastomosis, you'll be done. You'll be fine. Anterior always can deal with that. But if you face anastomosis and she's not coming from posterior wall, it's a disaster. You know.
Yes, you have right.
Abdullah, want to add something? Hussein, or you okay?
This is perfect what you just said. I'm glad you're mentioning these things because our new generation are only endovascular, rarely ever that they see open. So your point is very valid that I don't care about my stitch that is inside the aorta because I'm having here high flow, so I'm not concerned about any thrombosis. And even bridge, yes, even I could place the bridge inside. And for sure, well, infection, this is another thing, but even thrombosis, because of the high flow in the aorta, I'm not afraid of any thrombosis at that point.
Yeah,
absolutely. Yes.
And if you're afraid of infection, HASM, you can use a fascia, or something as a pledge, you know, or you can have a pledge.
Yes, you have right, and I use the pericardial patch also.
Yeah, as a pledge, you can use it. Yeah.
Because in PET-CT, lots of cases in re-PET-CT, they will be really illuminate, or there will be uptake for your so.
I don't think it's inaccurate. You know, I tell you how many cases I see lighting up on PET scan, and we do all the work, it's no infection. You know, and we have a couple of cases like that. The PET scan come back positive. Patient is normal, no WBCs. We stop the antibiotic, we do blood culture many times, negative, and there's no sign of infection, you know, even though lighting up a PET scan. So I don't think PET scan is 100% accurate, you know.
Yes.
Okay, so let's continue so don't keep you here for a long time. Who's talking now? Muhammad or who? Muhammad.
Yes, doctor.
Okay.
So what complication might occur following this operation?
Let's see what they say. The groin placement, autovenous, and also prefer rectus. What is infection here? Said.
Oh no, still we're still up, doctor. We moved.
We missed one, right? Yes. Patient has presented with exposed.
Yeah. So if the patient had presented with an exposed prosthetic graft in groin, how would you have altered management?
Okay.
Okay, so
patient if he comes exposed graft, yeah.
So first, prolonged antibiotic therapy.
Okay.
It will not cover the graft. I don't think this is the right answer. B, use vacuum dressing.
Okay.
Using vac, you have at least fascia or something to cover the graft before you put the vac. So
but
C.
You have a graft infection with a vacuum. What the problem is the graft infection? Get bleeding. So this is
they get bleeding and they fistulate usually. Yeah.
So I will not put a bank on infected
Yeah,
graft.
for
Unless
sure.
it's a muscle, it's a different story.
Yeah, we'll see C. C, simple coverage with a muscle flap without graft replacement.
Okay.
And this, he mentioned that this patient came with only exposed prostatic graft and there is no signs of infection. I think this will be a good answer. So,
Patient. We talk about this patient, actually.
yeah,
This patient. So
Yeah.
this patient, he already has an infected graft in the abdomen, and then he has also exposed prostate graft.
yes. Okay. So addition of muscle flap to graft replacement with autogenous vein.
Yes.
Yeah, this is the answer, right?
So let's talk about, which is, I think, very controversial, which is very important. Well, let's say if the patient comes with exposed graft only and no infection in that.
Yeah,
So
I
this,
thought he meant that.
yeah, that was, could be him. Let's see this scenario. He come like that, and the graft is only the graft, the growing graft is exposed. You do CT scan, no fluid around the graft, no, like, you know, bubbles around the graft, no air. So the question now, you still have to do the whole graft, or is enough to take this part of the graft? And I like to hear the consultant decision, because no right answers really. For me, let me tell you about me. I think I would just take this part of the graft. And I mean, during the surgery, you look like you start extending to the external iliac, the proximal graft. If you see the proximal graft is not incorporated in the tissue, this sign of infection. So then you have to take the whole graft out. But if you see the proximal part of the graft is really incorporated in the tissue, there is no infection, then you can use just local cleaning, and you put maybe just a muscle flap is enough. But if you go there and you see the whole graft is easy to be moved and not incorporated in the tissue, then you have to remove the whole graft. This is the way I would think about it. Hussein, what do you think? And Ali also, and Hazim.
I agree totally with you, especially if I'm concerned about the infection. I don't want this patient to suddenly bleed at night. So from the beginning, if the tissue is, or the graft itself is well covered with the tissue, that means it's just localized. So I'll probably irrigate, clean, and place a muscle flap to cover it, and cover him with good antibiotic. Otherwise, I don't want a nightmare, and for the safety of the patient, I'll go and remove everything. Because sudden graft, sudden bleeding, it will be a disaster for the patient, especially if there is nobody around him. You could just bleed like hell.
That's true. We have our share of this patient. I'm sure everyone has his share of this patient where they bleed in the middle of the night profusely, you know, they just open up, you know. So you have to be careful with that. Yes. What about Ali? What do you think, Ali? I know if Ali's still here. Maybe already left. Hazim, what do you think, Hazim?
As possible, I will take out everything. I will try to make a debridement, aggressive debridement, as possible.
No, we talk about the groin. Are you going to do towards the abdomen, do aorta by, take the aorta by fem, all of it, or just resect this part in the groin? And, you know, this is my main question. By fem, and he came with a groin infection. You go there, you see infection going to the graft, but you do CT's abdomen. There's no fluid around the graft, no, you know, no gas, nothing. So you just have infection in this part of the graft in the groin. So are you going to go and take the whole aorta by fem, or just deal with this local infection?
Wow, it's very important question, and very difficult actually. We had a couple of patients with such a scenario, and most of them were operated as aorto B femoral redo operation. But in couple of cases where the patient is not able to went or to underwent a big operation, we try to be more and to make more localization as treatment, but this is as ultima ratio. I think if you have infection, you should remove everything. I think so. It's should be removed, because in infection you will have a big concern that the infection is already attacked all the bypass in all length.
I mean, I agree with that, but I mean, it depends. I mean, if I see any fluid around the graft itself in the abdomen, like around the limb itself, then yes, I agree 100%. You know, if you don't have it, you can try at least, but there's no guarantee that this will work. But I will do just the minimum I will see. I just expose it, you know, clean it up, put some beads, get a muscle flap, and wash the patient, and see how things done, how he do, and if he do fine, it's okay. But you have to be on long-term antibiotic. But the best treatment is to resect everything if you can. But sometimes patients are sick, and you just want to give them a trial. So sometimes we can try that, yes, just to localize. But if you go and see CAT scan, you see fluid around the graft, even one limb, I think that's it. You have to remove the whole things, you know, just removal of the part will not be enough. So I think you go case by case, you know, and then you do muscle flap. The muscle flap, the most muscle flap we use, which one, Hamad? Muscle flap we use?
Usually Sartorius, and some people use Rectus.
Right. Or the second one, what else you can use?
Gracilis بعد or
Yes, or rectals, you know.
or Rectus, yeah.
Where place you cannot use Sartorius? Which area? Which can bypass? You know which one?
No, Doctor. Obturator?
No, if you do fem.
Yeah.
Superficial, the graft is very superficial under the above the ligament, you know. So it's very hard. So then it's better to use the rectus, you know, femoris. But if it's under the inguinal ligament, like ortho-bifem, then rectus, then Sartorius will work fine. Okay, let's go very quick. I think the rest complication. Now, let's go this one. Hamad, you are with us. Continue.
Okay, what complication might occur following this operation? Anastomotic hemorrhage.
Yes, it happened, right?
Yeah, it can happen. Yeah.
We're still doing an infection. So yes, next.
Graft rupture.
I mean, I don't see it. I never saw graft rupture. You know, you see anastomotic rupture, maybe in bleeding. The graft itself. I see aneurysm if you use a vein or use. I forgot to ask Hazim, how is the aneurysm? Because sometimes you use a vein, they cut aneurysm with the time. But I never saw a rupture. Next one.
DVT.
Okay.
Limb swelling, it can happen with DVT also, and limb swelling can happen with harvesting the vein.
Right, the femoral deep vein also could happen with this patient?
Yes.
Yes or no?
There is no femoral vein, but he can get iliac vein thrombosis.
Not get femoral.
Yeah.
You don't get DVTs, you know, because no femoral vein. Get swelling, already get DVTs already. Okay. Swelling.
Limb swelling.
Yes.
Seroma in the thigh.
Intestinal obstruction.
Yeah, intestinal obstruction can happen. Wound infection can happen also.
So what was asked? Yeah, Hazim, what about aneurysmal dilatation of the vein graft when you put in the aorta? Do you see it? Because the vein cannot take the pressure, it's very high. We see in AV fistula. What about in the aorta? This is one of the drawback of using vein in the aorta. What do you think?
Yes, I saw a couple of cases, and I saw also by one patient's vein rupture 2 days after the operation. It was last year also, and we lost this patient. I tried to operate him as emergency. I take him to the operation room, but we didn't achieve with the time. We lost him on the operation table. So yes, we have a lot of combination of complication, such as you said, such as aneurysm and such as ruptured, vein ruptured, especially if you are not trying to ligate the
Tributary.
Yes.
Yeah.
It's very important actually. And try always to secure your ligation with a 7 or 6-0 proline.
Okay. So you see rupture. I saw rupture patients, carotid, they put a vein patch. I don't do it, but some people, they put a vein patch for after carotid endarterectomy, and I see patient come with a rupture, carotid patch from the vein. So vein always, you have to, especially if it was not good quality vein, you have to be careful. Let's go to the last question so we can not stay here longer. Hamadia, you are with us. Let's continue here. So follow-up CAT scan.
Which routine follow-up investigation should be performed? Abdominal CT scan, abdominal ultrasound, graft duplex scan, abdominal X-ray, ESR. So so either duplex or CT scan صراحة.
But follow-up
you can
just better for because from the from EVAR looking for indolic, so you need a CAT scan.
CAT scan for this graft surveillance. It's you want to achieve it by the duplex scan. You can achieve it by duplex.
Because CAT scan or not is different. See, EVAR looking for indolic is no indolic. You're looking just is patent, iliac is patent. No fluid. So ultrasound, duplex ultrasound is more than enough. I think we're done. Right, we're done. Any question, guys, want to add? Then Ali.
Samer, just regarding the vein rupture for the carotid, I remember I worked with Peter Kalman in Toronto. All his carotid, he never used synthetic patch. He used the vein, but he inverted it, and he used it as a double layer rather than one single layer. I don't know, he told me that he never had, infection, definitely it's way less than the prosthetic graft. But I wonder that because he is using the double layer of a vein, maybe that's way less possibility to get that rupture.
Right. I mean, it's possible, make it thicker, but I tell you, I never use a vein because it just takes too long. There's no reason for that. I always, instead, I used to use a synthetic graft, a patch. When I came to Saudi, we started using a bovine patch. I'm telling you, I never saw an infection. And I'm sure I did quite a number of carotid. And I patch all my patients. I never see an infection. I don't think infection is too high,
Absolutely. Bovine is the best. Well, maybe his reason, Peter, is that he's getting double payment as harvesting a vein and that's business.
Yeah. You should go to the groin and take an hour and another extra hour, just make your surgery more complicated,
Absolutely.
Somebody was doing a virgin technique. Hazim, what do you do? A virgin technique, you do a patch, what do you use? This is very controversial, Even the guideline, they said the type of the patch should be left to the surgeon to decide. There's no guideline. Yeah.
So 85% till 90% we used a patch technique.
Yeah, what patch you use? What type?
Pericardial patch.
You ever had seen an infection?
No, I didn't saw any complications such infection by this kind of operation.
Yeah, I don't think it's an infection. It's a big deal. Yeah. All right, thanks. Thank you, everyone. Really, thank you, Hussein. Thank you, Hazim, and thank you, left for everything. So I really appreciate your help, guys, and hopefully we'll meet soon. Take care. Have a nice night.
Have a nice day.
Hazim, happy New Year. I tried to send you a WhatsApp. I couldn't find your WhatsApp. If you have my number, please send me a message.
Okay.
I will send you Hazim. I'll send you Dr. Hussein Kahlani number. I'll send to you.
Okay, Happy New Year also.
Okay.
Have a
you.
nice
Take
evening
care.
all.
Thank you, Hussein. And don't forget to share the material with us. It's really, you have a good experience with these things, you know. Try to share it with us in the group.
Thank you, sir. Thank you.
Thank you, everyone.
Have a nice evening.